There's an uncomfortable truth quietly unfolding in doctors' offices across the country, a conversation that could dramatically alter the health and happiness of your later years, yet one that is rarely had with the clarity and honesty you deserve. This is not a discussion about a new miracle drug or a groundbreaking surgical technique. It is a far more fundamental and urgent dialogue about the very philosophy of modern medicine as it is applied to the aging population. What if the very medical protocols designed to protect you, the routine tests ordered with the best of intentions for anyone over 70, were in fact a gateway to unnecessary anxiety, misdiagnosis, and a cascade of harmful treatments that can irrevocably diminish the quality of your remaining time on this earth? For decades, the healthcare system has operated on a deeply ingrained belief that more information is always better, that every shadow on a scan must be investigated, and that every deviation from a statistical norm must be aggressively corrected. This relentless pursuit of data, this medical maximalism, has become a dogma, but a growing body of evidence, coupled with my own 25 years as a urologist, specializing in the unique complexities of senior health, reveals a dangerous and heartbreaking paradox. We are now at a critical juncture where the accumulated wisdom of a long life must be allowed to meet and, in many cases, override the rigid protocols of standard medical practice. This is a point in time where simply complying with routine orders, nodding along to a doctor's well-meaning but often misguided recommendations, is no longer the safest path forward. It is, in fact, a path fraught with hidden dangers. This is not a radical call to reject medicine or abandon the incredible life-saving advances it offers. Instead, it is a passionate plea to reclaim your right and the right of your elderly loved ones to make truly informed choices. Choices that prioritize well-being over abstract numbers and dignity over diagnosis. For you or for the elderly parent or spouse you care for, the information that follows isn't just helpful or interesting. It could be the definitive key to preserving quality of life, avoiding devastating and iatrogenic complications, and ensuring that your golden years are genuinely golden, defined by vitality, joy, and independence, not by the painful and debilitating consequences of well-intentioned but profoundly misguided medical intervention. The quiet revolution in geriatric care begins not in a laboratory, but in the conversation you're about to have with your physician, armed with the knowledge and the courage to ask the right questions. Why more isn't always better after 70? The fundamental and arguably tragic flaw in modern medicine's approach to seniors is the unthinking application of a one-size-fits-all testing and treatment model. This model, which was largely developed and tested on younger, more resilient populations, fails to account for the profound biological and existential shifts that occur with aging. The risk-benefit calculation that makes perfect sense for a 50-year-old whose primary goal is the aggressive detection and eradication of any potential threat to a long and active life ahead can become dangerously and cruelly inverted for a 75-year-old. At a younger age, the body has a robust physiological reserve, the ability to bounce back from the trauma of biopsies, surgeries, and toxic therapies. The decades of potential life ahead justify the immediate sacrifices in quality of life. But after 70, and certainly after 75 and 80, the entire landscape changes. The body is different, with less resilience, slower healing, and a more delicate internal balance. Life expectancy is, by definition, shorter, and this is not a morbid fact but a critical variable in every medical decision. Many of the cancers or chronic conditions discovered through hypervigilant screening in this age group are so slow-growing, so indolent, that they pose no real threat to the individual's remaining lifespan. You are far, far more likely to die peacefully in your sleep of old age or from an unrelated event like a fall or heart failure with these conditions than you are to ever suffer a single symptom from them. The healthcare system, however, with its algorithmic checklists and its deep-seated fear of litigation, often fails to make this crucial, life-altering distinction. It continues to hunt for problems with ever more powerful and sensitive tools, but in doing so, it often creates new, more immediate, and more painful ones. An aggressive testing protocol in an older adult doesn't just lead to a diagnosis on a piece of paper. It triggers a devastating domino effect. It begins with the anxiety of an abnormal result, which then leads to invasive biopsies that can cause infections, bleeding, or pain. The discovery of a problem then leads to recommendations for major surgery, debilitating radiation, or powerful medications, each carrying its own significant risks. Risks that can shatter a person's independence, dignity, and overall quality of life. The question we must learn to ask and demand our doctors to answer is not, can we find something? But rather, will finding and treating this something actually lead to a longer and, more importantly, a better life for this specific individual in front of me? For a vast and growing number of seniors, the answer is increasingly and shockingly a resounding no. The pursuit of a clean bill of health becomes a destructive crusade that sacrifices the very well-being it claims to protect. The 5 tests you have the right to question. Over the course of my career, I have watched with growing concern as 5 specific medical tests, routinely and often automatically ordered for seniors, cause a wildly disproportionate amount of harm. These are not obscure or rare procedures. They are the bread and butter of preventative care for the elderly. Yet, they are the very procedures that most often initiate the downward spiral of overdiagnosis and overtreatment, converting healthy, asymptomatic individuals into anxious patients subjected to painful and debilitating interventions. These are the tests whose significant downsides your doctor may not voluntarily or fully explain, not out of malice, but due to the constraints of a busy practice, a reliance on outdated protocols, or a genuine but misguided belief that they are always doing the right thing. By arming yourself with a deeper understanding of the true risks and the often absent benefits of these tests, you can fundamentally transform your next doctor's visit. You can shift the dynamic from a passive appointment where you are simply told what to do into an empowered consultation where you are an active and respected partner in your own healthcare. This knowledge is your shield against the momentum of a system that too often forgets to prioritize the patient's actual well-being. PSA screening for prostate cancer. After age 75. This single blood test is perhaps the most egregious and harmful offender in geriatric male medicine. The prostate-specific antigen (PSA) test is notoriously unreliable, leading to an epidemic of overdiagnosis, yet it remains the primary catalyst for immense and often irreversible harm in elderly men. It is crucial to understand what this test is and what it is not. It is not a cancer test. It is a crude measure of inflammation or activity in the prostate gland, which can be elevated for dozens of benign reasons, including a recent bicycle ride, a simple urinary tract infection, or even benign prostatic hyperplasia, BPH, a non-cancerous enlargement of the prostate that affects the majority of older men. Despite this unreliability, a slightly elevated number on a lab report unleashes the hounds of medical intervention. The U.S. Preventive Services Task Force, one of the most respected and evidence-based authorities in medicine, explicitly and strongly recommends against routine PSA screening for men over the age of 70. The rationale for this recommendation is crystal clear and based on overwhelming data. Prostate cancer found at this advanced age is typically a biological tortoise, not a fast-moving hare. The vast majority of these cancers are low-grade and so slow-growing that they would likely take 15, 20, or even more years to become a clinical problem, a timeline that far exceeds the average remaining lifespan of the man in question. But the medical system is conditioned to react to the number. The elevated PSA leads to a recommendation for a prostate biopsy, a painful and invasive procedure where multiple needles are shot through the rectal wall into the prostate, carrying a significant risk of introducing dangerous bacteria into the bloodstream, leading to sepsis, a life-threatening infection. If this biopsy manages to find a small pocket of low-grade cancer, the patient is then counseled on the need for treatment, typically surgery or radiation. These treatments have devastatingly high rates of permanent, life-altering side effects. Radical prostatectomy frequently leaves men with total urinary incontinence, condemning them to a life in diapers, and near certain erectile dysfunction, robbing them of their intimacy and a core part of their identity. Radiation therapy can cause chronic rectal and bladder pain, bleeding, and long-term urinary problems. In essence, an elderly man is asked to trade his daily quality of life, his continence, his sexual function, his dignity, to treat a cancer that was, in all likelihood, content to sleep peacefully and harmlessly for the rest of his natural life. There is zero proven survival benefit for screening and treating men in this age group, only a proven and substantial harm. Routine colonoscopy after age 75. The colonoscopy is rightly hailed as a lifesaver for middle-aged adults, a powerful tool for preventing colorectal cancer during the peak years of risk. However, like so many medical interventions, its risk-benefit profile undergoes a dramatic and dangerous shift in the later years of life, particularly for individuals who have a history of normal screenings. For an older adult, especially one with underlying health issues or a degree of frailty, the procedure itself becomes a significant medical challenge. The preparation process alone can be debilitating. Consuming gallons of a powerful laxative solution can lead to severe dehydration, dangerous electrolyte imbalances, and kidney strain. The sheer physical stress of the prep, with its urgent and repeated trips to the bathroom, can cause weakness, dizziness, and dramatically increase the risk of a fall, which can be a catastrophic event for a senior. More seriously, the procedure itself carries a significantly higher risk of severe complications in elderly patients. The walls of the colon become thinner and less flexible with age, making the instrument-related risk of a bowel perforation, a tear in the colon wall, 3 to 4 times higher than in a younger patient. A perforation is a life-threatening surgical emergency, often requiring immediate major abdominal surgery, a potential colostomy bag, and a long, difficult, and often incomplete recovery. Furthermore, if a polyp is found and removed, the subsequent risk of post-procedural bleeding is also much higher. The American College of Physicians, another leading medical authority, explicitly advises against routine screening colonoscopies for average-risk adults over the age of 75 and for any adult with a life expectancy of less than 10 years. They have done the math and recognized that the potential for immediate, severe, and life-altering harm from the procedure itself far outweighs the tiny statistical chance of finding and preventing a cancer that would have impacted their natural lifespan. Yet, the once every 10 years mantra is so ingrained that these procedures are often ordered automatically without a thoughtful, individualized discussion of these very real and present dangers. Routine mammogram screening after age 75. The logic for questioning routine mammograms in the very elderly closely mirrors the reasoning for prostate cancer screening, yet it is a topic that is even more rarely discussed with patients. Breast cancer screening in women over the age of 75 frequently leads to the discovery of slow-growing, indolent cancers, particularly ductal carcinoma in situ, DCIS, which many experts now consider a non-invasive precancer that may never progress to a life-threatening state. A major landmark study published in a leading medical journal delivered a sobering and practice-changing fact. While mammograms in women over 75 did, in fact, detect more instances of breast cancer, the aggressive treatment of these cancers did not improve their overall survival rates by one single day. The women who were screened and treated lived no longer than the women who were not. What the treatment did do, however, was subject these elderly women to a gauntlet of physically and emotionally damaging interventions. It subjected them to surgeries, which carry higher risks of anesthesia complications and poor healing in older bodies. It subjected them to weeks of debilitating radiation therapy, which can cause painful skin burns, chronic fatigue, and damage to the underlying heart and lung tissue. It subjected them to hormonal therapies or chemotherapy that ravaged their remaining quality of life, with side effects like joint pain, cognitive fog, and nausea, all without extending their lives. The harm here is not just the initial anxiety of a false positive result. It is the very real, tangible physical damage and the theft of precious, good quality time from treating a disease that posed no imminent threat. It is the tragedy of a woman spending her final years feeling like a sick cancer patient, enduring painful treatments when she could have been enjoying her grandchildren or tending to her garden, completely unaware of a clinically insignificant cluster of cells that would have never caused her a moment of trouble. The medical imperative must shift from simply finding cancer to determining if finding that cancer will actually help the patient live a longer or better life. For many women in this age group, the evidence overwhelmingly suggests it will not. Aggressive diabetes screening and tight glucose control. Managing diabetes is undeniably crucial at any age, but the approach must be intelligently and compassionately tailored to the individual, especially for a frail elderly person. For decades, the goal in diabetes management has been to push for extremely tight glucose control, aiming for a hemoglobin A1C, a marker of average blood sugar over 3 months, below 7.0. While this is a reasonable goal for a younger, healthier person to prevent long-term complications like kidney and eye disease 20 years down the road, imposing this rigid target on an older adult with a more limited life expectancy is not just unnecessary, it is profoundly dangerous. The primary and most immediate risk of aggressive glucose-lowering therapy is hypoglycemia, a sudden, severe drop in blood sugar. For an elderly person, a hypoglycemic episode is not a minor inconvenience. It can cause profound confusion, dizziness, blurred vision, and a loss of coordination, leading directly to falls, which are a leading cause of disability and death in seniors. A fall can mean a broken hip, a head injury, a lengthy hospitalization, and a rapid decline into dependency and immobility. Multiple large-scale clinical trials have yielded a shocking and counterintuitive result. Imposing this aggressive tight glucose control in elderly populations actually increases mortality and serious adverse events rather than decreasing them. The daily high-stakes risk of a fatal or disabling hypoglycemic event far outweighs the theoretical long-term benefit of preventing complications that the patient may never live long enough to experience. In recognition of this overwhelming evidence, the American Diabetes Association has now officially changed its guidelines, recommending more relaxed and sensible A1C targets for seniors with a limited life expectancy, typically in the range of 7.5 to 8.5. The goal is to prevent the symptoms of high blood sugar, not to chase a dangerous, abstract number on a lab report. And yet, countless physicians, operating on outdated knowledge, continue to push their elderly patients to achieve dangerously low A1C levels, putting them at daily risk of a catastrophic event for a theoretical benefit they will never see. Routine, just in case, CT scans, and extensive imaging. This practice represents the true Pandora's box of modern geriatric medicine, a technological marvel that has been turned into a potent engine of iatrogenic harm. It often begins with a vague complaint, a mild abdominal pain, a cough, a bit of dizziness. A doctor, wanting to be thorough and just to be safe, orders a comprehensive CT scan of the chest, abdomen, and pelvis. In the body of an 80-year-old, a lifetime of living, of minor illnesses and healed injuries has left its marks. Consequently, the high-resolution scan almost always finds something. A small, benign nodule on the lung, a simple fluid-filled cyst on the kidney, a small hemangioma, a harmless tangle of blood vessels, on the liver, a thickened bit of bowel wall. These findings are called incidentalomas. Incidental findings that are, the vast majority of the time, clinically insignificant scars and artifacts of a long life. They would never grow, never spread, and never cause a single symptom. But once they are seen on a high-definition screen and documented in a radiologist's report, they cannot be unseen. The medical legal climate and the physician's own anxiety create an irresistible pressure to chase these findings. This triggers a frantic and often terrifying cascade of more tests, more scans with contrast dye that can be harmful to older kidneys, and invasive procedures like needle biopsies of the lung, liver, or kidney to investigate something that should have been left entirely alone. One landmark study found that these follow-up procedures to investigate incidentalomas caused significant complications in nearly a quarter of the elderly patients who underwent them, including collapsed lungs, major bleeding, and infections, all while providing absolutely zero improvement in their survival or quality of life. The initial just-in-case scan, ordered with the best of intentions, becomes the first step on a journey of fear, pain, and real physical harm, all in the pursuit of a diagnostic certainty that brings no clinical benefit. A story of a life reclaimed. Let me tell you about Arthur, a gentleman who walked into my office a few years ago, a 78-year-old retired carpenter with a weary, worried look in his eye that I have seen all too often. Arthur still had the strong, calloused hands of a man who had built things his entire life, but his shoulders were slumped under a weight that had nothing to do with physical labor. His primary care doctor, a good physician simply following the standard community protocol, had ordered a routine annual PSA test as part of his senior wellness check. The result came back slightly elevated at 4.5 ng/ml. This single number, barely above the arbitrary cutoff for normal, set in motion a chain of events that nearly ruined his life. He was immediately referred to a local urologist who, citing the number, insisted on a prostate biopsy. The biopsy procedure itself was painful, but worse, it caused a severe infection that led to a high fever and a week-long hospital stay for intravenous antibiotics. The ordeal left him weak and shaken. The biopsy results eventually came back, finding a tiny amount of low-grade Gleason 6 prostate cancer in one of the 12 core samples. His urologist sat him down, used the terrifying word cancer, and, citing the need for decisive action, strongly recommended an immediate robotic prostatectomy surgery. When Arthur came to me for a second opinion, he was terrified. He felt a clock was ticking, that this cancer was a time bomb inside him. The first thing we did was not to look at the pathology report, but to look at him. We talked about his life. He loved his garden, he played with his grandchildren, he and his wife enjoyed their daily walks. He had some mild heart disease and arthritis, but overall, he was a happy, functional 78-year-old. Based on his complete health picture, his realistic life expectancy was about 8 to 10 years. The type of low-grade cancer he had, if left entirely alone, would take at least 15, maybe 20 years to grow to a point where it might cause any symptoms. He was facing a stark choice: undergo a major, life-altering surgery that would all but guarantee permanent incontinence and impotence for the rest of his days, all to cure a cancer that was virtually guaranteed never to harm him, or to have the courage to do nothing but monitor it with occasional blood tests. He chose the path of wise inaction. I saw him 5 years later for a checkup. At 83, he was vibrant, still proud of his tomatoes, and enjoying his life fully with his wife. His PSA had barely nudged. The cancer had not changed. Had he followed that initial aggressive protocol-driven advice, he would have spent his final precious years in diapers, socially isolated, robbed of his dignity and intimacy, for no survival benefit whatsoever. His story is not an exception. It is a tragically common scenario that plays out in thousands of offices every single day. Your 3 questions to reclaim. Control. The power to prevent this kind of medical misadventure from happening to you or your loved ones does not lie in a new technology or pill. It lies in your own voice. It lies in your ability to ask the right questions, to challenge the inertia of the medical system, and to insist on care that is personalized to you as a whole human being, not just a set of lab values. Before you agree to any of these potentially harmful tests after the age of 70, you must become your own most powerful advocate. Here are the 3 non-negotiable questions you must ask your doctor. Their answers will tell you everything you need to know about whether you are on the right path. 1. Considering my complete health picture, including my heart, my mobility, and everything else, what is my realistic life expectancy? And based on that specific time frame, am I statistically more likely to die with this potential condition you are looking for or from it? This is the single most important question. It immediately forces a shift from a generic, one-size-fits-all protocol to a deeply personalized assessment. It respectfully demands that your doctor look beyond the screening guideline and consider you as an individual. If your realistic life expectancy is less than 10 years, the vast majority of cancer screenings, particularly for prostate, breast, and colon cancer, offer far more potential for harm than for help. You are looking for an honest, thoughtful answer, not a vague platitude. A doctor who is truly practicing patient-centered care will welcome this question and engage in a frank discussion about competing risks and priorities. A doctor who dismisses it is sending a clear signal that they are treating a protocol, not a person. 2. If this test finds something, what exactly would the proposed follow-up and treatment involve? I need you to be very specific. What are the most common risks and side effects of that treatment? And how would they impact my quality of daily life, my ability to walk, to control my bladder, to think clearly, to enjoy my hobbies? Do not accept a vague answer like, "We'll cross that bridge when we come to it." The time to evaluate the bridge is before you take the first step onto it. You need to understand the full downstream consequences of a positive test. If the likely treatment for whatever the test might find involves side effects like permanent incontinence, chronic pain, cognitive fog, or severe fatigue, and these side effects are a greater and more immediate threat to your personal well-being and independence than the slow-growing disease itself, then the test may not be worth the risk of opening that Pandora's box in the first place. You are not just consenting to a test, you are potentially consenting to the entire cascade that follows. 3. What does the latest medical evidence, not just the standard hospital protocol from 10 years ago, but the most current age-specific studies, show about the benefits versus the harms of this particular test specifically for someone my age and in my overall state of health? This question demonstrates that you are an informed and engaged participant in your healthcare. It is a polite but firm way of asking for evidence-based medicine, not just medicine by habit. Many hospital and clinic protocols are slow to change and may not reflect the latest scientific consensus from leading bodies like the U.S. Preventive Services Task Force or the American College of Physicians. You have the right to demand care that is based on the most up-to-date science for your specific demographic. A doctor's order is a professional recommendation, not a military command. It is the beginning of a conversation, and this question ensures that conversation is grounded in facts and tailored to you, not to an outdated flowchart. Beyond the doctor's office, supporting your vitality. Naturally taking control of your healthcare decisions and engaging in these crucial conversations is the most critical and empowering step you can take toward ensuring a high quality of life in your later years. It is about making a fundamental shift from a position of passive compliance to one of empowered partnership with your medical team. But while you are wisely navigating the healthcare system and avoiding the significant risks of unnecessary medical interventions, you can also be proactively supporting the very foundation of your health and vitality from within. This is not about finding an alternative cure. It is about nurturing your body's innate resilience and strength so you can reduce the need for aggressive medical oversight in the first place. It's about building a body that is robust enough to make the conversation about overtesting less frequent and less urgent. That's why I often talk to my patients about complementing their informed medical choices with intelligent, natural support. It's about a two-pronged approach. Avoid the harms of overtreatment while actively bolstering your own wellness. For those looking for a simple yet effective way to provide gentle, daily maintenance for their cardiovascular health and natural energy levels. I often recommend a high-quality organic watermelon extract. This is not a complex pharmaceutical, but a pure natural compound rich in L-citrulline. L-citrulline is an amino acid that your body converts into nitric oxide, a crucial molecule that helps relax and widen blood vessels, promoting healthy circulation throughout the body. Good circulation is the foundation of all health. It delivers oxygen and nutrients to every cell, supports healthy blood pressure, and is essential for physical energy and cognitive sharpness. It is a safe, gentle way to support the body's core functions without the risks and side effects associated with many prescription drugs. However, if you are looking for a more comprehensive and synergistic approach to truly optimize your health, to not only avoid the pitfalls of harmful tests, but to actively enhance the energy, cognitive function, hormone balance, and physical strength that define a vibrant and independent life, I suggest considering the Advanced Senior Vitality Formula. This is a thoughtfully combined blend of nature's most effective and well-researched ingredients for promoting healthy aging in a holistic way. It includes icarin from horny goat weed, which has been shown to be a powerful supporter of nitric oxide pathways for robust circulation and physical energy. It contains tonkat ali, a remarkable botanical known for its ability to support the body's natural hormone balance, which is crucial for maintaining muscle mass, bone density, and vitality as we age. It features fenugreek for its role in supporting sustained energy metabolism and healthy blood sugar levels. It also includes nettle root, which has a long history of use for gently and naturally supporting prostate health, offering a proactive, non-invasive way to maintain the very organ that conventional medicine so often targets with aggressive and harmful procedures. Finally, it is fortified with a concentrated dose of L-citrulline to provide a powerful foundation for peak cardiovascular function. Together, these elements work in concert to build the kind of robust, resilient health that allows you to thrive, making your informed medical choices from a position of strength and intrinsic wellness. Remember, the ultimate goal after 70 is not just to live longer, but to live better. True health is found not in the quantity of your medical tests, but in the wisdom of your choices and the vitality of your life.